Good afternoon. I'm Heidi Winkowski, and I'll be your moderator for the day. Welcome to SonoSim's webinar focusing on the use of sonography to evaluate pediatric lung pathology. All attendees will be in listen-only mode and may ask our host questions during and after the session in real time through the webinar chat. A recorded version of this webinar will be available after our session. If you're just joining us, welcome. Now it's my pleasure to introduce Dr. Eric Savitsky, Professor of Emergency Medicine and Pediatric Emergency Medicine at the University of California, Los Angeles. Dr. Savitsky will discuss sonographic characteristics of the more commonly encountered pediatric respiratory conditions, with special emphasis on diseases of neonates and infants. Welcome, Dr. Savitsky.
Great. Heidi, thanks for the introduction. Pleasure to be here virtually with everyone. And it's actually been nice to get up to a couple conferences and see everybody live and in person. So that was great. So here to talk about pediatric lung sonography. So that's the topic we're going to discuss in today's SonoSim webinar. And was going to do it over a course of about 20 slides. So was going to go through 20 slides, put the pediatric lung sonography module in context in terms of the broader ecosystem that SonoSim provides, but a majority of the slides, 18 of them, are really going to be focused on pediatric lung sonography, and really talking about the technology, the tools, how you can apply them, and really excited about this. So I'll get into that shortly. So diving into pediatric lung ultrasound. So the indications are many, everything from detecting pneumothoraces to screening for lung consolidations, detecting alveolar interstitial syndrome or interstitial syndrome, which is another term for it, assessing pleural effusions, guiding ultrasound-guided thoracenteses, documenting endotracheal tube positioning, thoracostomy tube positioning, as well as detecting a variety of congenital lung malformations. So you can see the applications are broad. One of the best quotes when I was learning about pediatric lung ultrasound that I came across was by Lichtenstein, so one of the godfathers of lung ultrasound. And his quote is, "Physicians master lung ultrasound in the critically ill when they can master its limits." And that's really prescient and a very accurate saying, in the sense of you have to understand the limitations of lung ultrasound and actually what you're looking at, because so much of lung ultrasound does rely on the integration in a clinical decision making. And whether you're a point of care user or sonographer, for sonography, understanding the pleura and the lung, just because it's seen in so many of your image windows, whether you're doing echocardiography, if you're on echo track, or if you're on just doing a general abdomen and you're looking at soft tissue or the thorax, it's really important to understand what the lung and underlying lung parenchyma and pleura, what that looks like. And for point of care users, the applications are super important. My background, kind of wearing the academic hat, is emergency medicine and pediatric emergency medicine. And in terms of from approaching pediatric patients, especially going into flu season and potentially, another winter of COVID, hopefully at a low grade, seeing a patient come in with fever and a cough, and they're 1, 2, 3, or 4 years old, differentiating a bacterial pneumonia from a viral pneumonia clinically can be incredibly difficult, relying on x-rays due to the radiation risk and just the inconvenience, cost, and time and efficiency versus being able to walk into that patient's room and during that visit with the parent and the child, be able to walk out of the room with a high degree of confidence because you've screened the lung sonographically, and it's actually more precise in the trained operator's hands than a plain radiograph. That's an incredibly powerful tool. That's what I want to talk about today, and share some of the background information from our pediatric lung sonography course with everybody. So, to start with, pediatric lung ultrasound, the name of the course, in some ways is a misnomer. In a normal patient, you're not going to see the lung. And the reason is, your lung is aerated and air is going to block the ultrasound signal. So for the most part, in a normal patient, what you're going to see is what you see in this image, where you see soft tissue, you see rib shadows, and you're going to get a hyperechoic cortex here. And depending on the age of the patient, if it's a neonate, you actually many times can scan through the rib because it isn't super well mineralized, so it doesn't block the ultrasound signal transmission. But as patients get older, you'll get this dropout and this shadowing, and then you're going to see the pleura. And the pleura is, very, very thin, zero point 0.2 to zero point 0.3 millimeters in normal patients. And the other thing that makes pediatric lung ultrasound a little bit of a challenge is there's really no consensus on nomenclature. There's a variety of consensus groups and guidelines that have put out some attempts at unifying the nomenclature, but B-lines, for instance, have been referred to as comet tail artifacts, ring down artifact, lung rockets. Alveolar interstitial syndrome goes by interstitial syndrome, as well as a variety of other names. So there's a lot of varying nomenclature, and we'll try to unify that today. And then the most important part of lung ultrasound, once again, is having to take your findings, your sonographic findings, and integrate them into the clinical context of the patient. And when you're able to do that, that's when you can extract maximal value out of lung ultrasound. So a little bit on transducer selection. So when I first started doing lung ultrasound, I was really wed to high frequency linear transducers. And in neonatal and young infants, that's a great modality, and you usually can get everything that you want. But as I started to use it in adult patients or older pediatric patients with bigger body habitus, you will have progressive value in your curvilinear transducer just because of the deeper image penetration of the signal. Also, depending on what you're looking at, the different frequencies will highlight different structures. For instance, if you're trying to really look at the pleura and see if the pleura is thickened, and really get a general sense of that, the high frequency linear transducer will allow that. And once again, in neonates and infants, you for the most part can see a majority of what you can see in the far field adequately with a linear transducer. As patients get older, as we talked about, the curvilinear transducer really helps see B lines. So it helps get deeper image penetration into the patient's body. And then also with larger body habitus patients, you just need that lower frequency transducer signal to actually see what you need to see, just to penetrate the soft tissues. It is really important to disable any type of image filters. A lot of the image filtering that go in will degrade some of the B lines and make interpreting some of the artifacts that arise that help you interpret lung ultrasound difficult. So it's important to disable any post-image acquisition filters. That's very different than potential some presets that have some ALARA implications. So what I mean by that is ALARA principles are always helpful to talk about. So it's using ultrasound and limiting basically the acoustic power as low as reasonably achievable to get you the image that you need to kind of make a clinical decision. So some terms that you'll see that's important to recognize: thermal index and mechanical index. So these are terms that are used to describe the bioeffects of ultrasound energy. And thermal index is defined as the ratio of the emitted acoustic power to the power required to raise the temperature of tissue by 1 degree centigrade. And the thermal index will depend a little bit if it's bone, cranial bone, or soft tissue. So it varies depending on the structure. Mechanical index estimates the risk of physical perturbations associated with ultrasound signal pulse transmission through tissues. The default values that for all patients, with the exception of ocular applications, a TI of less than or equal to 0.7 and an MI of less than or equal to 0.4 for the most part have negligible bioeffects. And with ocular, the threshold's a little bit lower, but for the most part, if you pick the correct image preset for the application, this will get pre-selected for you, and it'll be displayed in the upper portion of your ultrasound window, as you can see here. So it's just important to be aware of that, especially when you're doing Doppler applications, ocular applications, OB, especially early stage OB applications, just to be aware of that and make sure you follow your presets. They're there for a reason. All right, so when we get down to doing lung ultrasound, there's a toolkit, I like to say. So there's a set of tools that if you're able to leverage these tools and understand these findings, then you can really derive maximal value from lung ultrasound. Probably the most important thing to really appreciate is lung ultrasound and detecting whether it's B lines or pathological findings is only as good as where you look. And many times in point of care, you're finding time constraints, potentially uncooperative patients or patients that are in positions that make them difficult to examine. And traditionally, you're taught to scan in a longitudinal axis of the body. So you scan down, and when that's done, Milner and Son did a study in pediatric patients. Median age was about 3 years of age. And they looked at, if we just look longitudinally, how sensitive would that be for detecting consolidations? And they're about 85% sensitive for detecting consolidations when you use a parasagittal imaging plane. Conversely, if you actually take the transducer and you rotate it into a transverse oblique plane, and you actually scan in between the ribs along the intercostal space, and you can actually trace it out laterally as well as posterior laterally, there all of a sudden the sensitivity went up to 96%. And many times I'll use a combination of both approaches, and the more you can do that, the more sensitive ultimately your examination is going to become. So really important to appreciate the different planes that you can scan, and if you don't do that, invariably you'll miss your occasional smaller consolidations. And just remember, you're trying to cover the anterior thorax, anterior lateral maxillary line of the thorax, and then posteriorly you want to come up just medial to the scapula and follow around inferolaterally along the scapular edge. And you're able to do that in pediatric patients very, very easily. Just let the parents know that it doesn't hurt. It's just going to be cold. You have a nice towel, hopefully a warm towel to warm off your patient. And you just go in there, you do your exam as you're talking to the family after you've done your auscultation or before. And you can come out with a really, really good understanding of what's going on in that patient's thoracic cavity in terms of pathological findings. So some terminology, just so we're all on the same page. Lung pleura. So just identifying the pleura. This is often, stumbling block number one, where unless you identify the ribs and the soft tissue, and then think about the pleura should be about, a half centimeter to a centimeter below the rib margins. You should identify the pleura because it can be very easy to mistake it for either a rib margin or, a fascial plane above it. The lung pleura, once again, 0.2 to 0.3 millimeters normal thickness. And then what the pleura does is it should slide. You have visceral and parietal pleura layer. You really can't differentiate between the two. And if you actually look with grayscale or you apply color flow Doppler, you'll see some movement. And typically that movement, you're going to see ribs moving as you take an inspiratory and expiratory effort. And the pleura in some ways are going to move, but they're not going to necessarily track. They're going to move in two planes and not necessarily track the exact movement of the ribs. So there'll be a little bit of kind of asymmetry in that movement, and that very often helps identify that lung sliding. So once again, you can apply color flow Doppler and MO Doppler, and those are some additional modalities which we'll talk about that can further help document that there is lung sliding present. There's A-lines. And what A-lines are, you can see these A-line artifacts. These are reverberation artifacts that are essentially the ultrasound signal hitting the pleura, bouncing up to the ultrasound transducer and creating that reverberation effect where you have equally spaced hyperechoic lines that are equidistant below the pleural line. Those are normal, seen in normal patients, and do not indicate any pathology. When you look over here to this image, this is dramatically different. So this is a neonate with a white lung appearance, and you can see there is no real pleural line that you see. You see a lot of pleural irregularity, and that's a pleural defect. And that's indicative of pathology of the subpleural region of the lung, where there is loss of aeration, and the ultrasound signal penetrates through the pleura and through the lung immediately underneath it due to that loss of aeration. And you wind up losing the visualization of the pleura, and that's indicative of pathology. So that's what a pleural defect in this case, multiple pleural defects look like. All right, so talking a little bit about B-lines, and we'll define what causes B-lines shortly. And the terminology, once again, you can hear B-lines, lung rockets, comet tail, artifact, many different terms. What we're going to use to simplify things is you have B-lines, you have multiple B-lines, you have coalescent B-lines, and then you have a white lung pattern where the B-lines are essentially confluent, and we'll show some examples of this. So here you have basically what looks like the margin of the diaphragm. This is either going to be the liver or the spleen. Margin of the diaphragm is here. Here you have lung sliding, and here you have an occasional B-line. So occasionally you'll see a hyperechoic laser-like signal that goes down the entire screen from near field to far field. So that's an occasional B-line. And once again, you can have 2 to 3, typically less than 3 B-lines, and it's usually more accentuated in normal patients as you get near the margin of the diaphragm just due to likely some atelectasis. But that's normal. So when you're looking at ribs and short axis, 1 to 2 B-lines is a normal finding, especially down near the margin of the diaphragm. Here you have multiple B-lines. Now you're having multiple laser-like projections between 2 ribs and short axis, and this is pathology and pathologic. And we'll talk a little bit about the differential shortly, but this is what multiple B-lines look like. And then when you have coalescent B-lines, where the B-lines come together and they're so diffuse, the entire lung in certain parts of this clip are whited out. And it's the difference of coalescent B-lines, where they're much thicker because they've coalesced. And then if it occupies your entire screen, as it does in certain areas here, and here we're looking through a transverse oblique plane, so we're getting into the intercostal space. And you can see in certain imaging planes, there's a white lung appearance. So there's just diffuse involvement. And the B-lines are so closely spaced together and coalesced that it creates that white lung appearance. So that's a little bit on terminology. And in terms of B-line pathology, what causes B-lines? There's 3 underlying pathophysiological processes that lead to B-lines. But essentially there's excessive extravascular fluid. And that fluid can either be in the terminal alveolar unit, so within the alveolar sacs, or it could be surrounding the alveolar sacs in the interstitium. So an excess of fluid either within the alveolar sacs or in the interstitium, hence the term alveolar interstitial syndrome, or interstitial syndrome is how that term arises. Similarly, you can get very similar patterns. Some people have described the B-lines as potentially being a little bit thicker with interstitial inflammation or fibrosis. So think of all your patients that develop interstitial lung disease and fibrotic changes. Those same B-lines can be seen in those disease processes. And then the interstitial infiltrative process, connective tissue diseases, sometimes malignancies, can lead to that. And essentially what happens is the B-lines, whether it's fluid, inflammation, or interstitial infiltrative process, you lose aeration. And whether it's fluid accentuating signal transmission or the loss of aeration limiting the blockage of ultrasound signal, you wind up getting transmission of ultrasound signal through the lung parenchyma. And that's what actually creates the B-lines, which you're able to visualize. And in some situations, depending on the degree of a loss of aeration, you'll actually start to see some lung parenchyma. We'll discuss that shortly. But the generation of the B-lines, once again, results from any one of those 3 processes or a combination of those, and it allows that ultrasound signal to penetrate through the pleura and create these vertical reverberation artifacts that are termed B-lines. All right, so we started to allude to this a little bit earlier. So the other term to become familiar with is lung consolidation. And once again, when you say lung consolidation, you actually wind up seeing the lung. And like we started this discussion, you don't see normal lung parenchyma in a normal healthy lung. When you actually do see the lung, and in lung consolidation, you're actually visualizing the lung parenchyma, which is what you're seeing here. And the reason you're visualizing it is that part of lung is consolidated and it's lost aeration. So the ultrasound signal is actually able to penetrate into that lung parenchyma. Many times, depending on the degree of aeration, plus minus the degree of inflammation or fluid within that segment of lung, you get what's called a hepatized lung appearance or a tissue-like appearance to the lung. Similar to that, with many lung consolidations, you get an irregular pleural surface. Here, there's basically the pleural line completely drop out. The margins along that consolidation many times are irregular. Sometimes they can be regular with atelectasis that favors atelectasis. With infectious processes that lead to consolidation, they tend to be irregular, and this looks like an irregular margin. You see these bright hyperechoic signals within the consolidation, and those are air bronchograms. That's air trapped in a bronchus that can be static or can move to and fro as the patient breathes in and out. And then lung sliding can be present or can be absent depending on if you can even see the lung pleura. And in this case, with this focal consolidation, there's a dropout of signal. So this is lung consolidation, just defining the terminology. And we'll talk about the differential shortly. So when you scan and you dynamically look at the images, these are transverse oblique images. The image on the left is obtained with a curvilinear transducer. And here, once again, you see a focal consolidation. It's relatively large. It's like 4 or 5 centimeters. Irregular margins. You see some dynamic air bronchograms where you see air moving to and fro that's trapped in here, and that's very suggestive of a bacterial pneumonia. And then here, this is a different pattern. Here you have almost a white lung appearance. The pleura is irregular, but here you have a consolidation. It's very small. It's less than a centimeter. If you look at the at kind of the depth markers. So this is a focal subpleural consolidation. So a very, very small area. And then here you see some irregularity, the margin, and then a hyperechoic signal below it. And this has been termed a shred or fractal sign. So this is a subpleural consolidation that's accompanied by an irregular deep border of consolidation and aerated lung. And once again, that little sign is called a shred or fractal sign, very commonly seen with subpleural consolidations that are very often seen with viral pneumonias. COVID-19 has been one of those that this is a very commonly seen lung finding. All right, a couple additional terms to review here. So on the left, we see the lung sliding that we've discussed. So very clear to and fro movement of the pleural line. But that should be differentiated from a lung pulse, which is here, what we see in the second image. This is, once again, a transverse oblique plane, so you're seeing in the intercostal space, and you're looking at the lung. And the difference here is you see to and fro movement, but it's moving or pulsating at a super high rate. So this is looking like 60 to 80 times a minute, and you can look at the patient in front of you, and if there's a disconnect, and that doesn't represent the patient's visible respiratory rate, many times this is cardiac pulsation that's being transmitted to the pleural line. So this is what's called a lung pulse. Still can be helpful in excluding a pneumothorax, because with a pneumothorax you'd have air and you wouldn't necessarily be seeing that lung pulsation due to the air of the pneumothorax potentially blocking the signal transmission. So a lung pulse can still be helpful in ruling out pneumothorax, but it should be differentiated from lung sliding. So they represent two different physiological phenomena, and it's important to differentiate those two. Here you see the most specific indicator for pneumothorax. So the most specific finding is a lung point. Here's a CT scan that shows a pneumothorax. It's loculated, it's anterior. Here's the margin of where the pneumothorax is no longer present, and you actually see lung pleura. And this ultrasound is taken right at the margin here, where you get part of the lung where you would see lung sliding, and then you're also visualizing part of the lung that has the pneumothorax. And when you look within this image, along the left of the image, you see lung sliding. And then there's a discrete point where that lung sliding stops. And along the right side of the image, you see very static A lines that is that reverberation artifact. And that transition point is a lung point. What you've done there is you've identified the location, the height of the pneumothorax, where you have lung sliding with no pneumothorax, and then you have the loculated air with no lung sliding because the air is blocking signal transmission. And, and that represents the junction of the pneumothorax, and it's a very, very specific sign or finding that does represent a pneumothorax with a high degree of accuracy. All right, next thing that we're going to discuss is, now that we've gone through and defined all these terms, so this is our toolkit. So we have all these terms: lung sliding, lung pulse, A-lines. We've looked at pleuras, talked about lung consolidations. Here it's really important to take that information and marry it to clinical context and apply it. So we're going to go through doing that, and then we're going to scan 3 real cases shortly and apply them clinically. So talking about pneumonia patterns. So when you're trying to take findings, whether they're B-lines or lung consolidations or subpleural consolidations, and trying to say, does it represent a bacterial pneumonia or a viral pneumonia? In general, using plain radiographs, and it's been very difficult to get consensus definitions of what represents a bacterial pneumonia and a viral pneumonia for a variety of reasons. But in general, as a generality, bacterial pneumonias have an alveolar pattern, like you see here on the left. Viral infections tend to have an interstitial, more diffuse infiltrative pattern, like on the right. And about 10% of the time, patients with viral pneumonias develop bacterial superinfections. So they tend to have an overlapping pattern when you look at patients during peak flu seasons. So this is the general pattern that you see using plain radiography and kind of the underlying pathophysiology. Now, what does this look like on lung ultrasound? So once again, for bacterial pneumonias, when you're looking at a patient with lung sonography, you tend to see focal B lines. As you can see here in this patient, there's a bacterial pneumonia here in the right chest. So you would potentially see focal B lines. Here you would see some consolidations that aren't small. They tend to be generalized and not focal, meaning not less than a centimeter. They tend to be larger than that. You may see dynamic air bronchograms, and you may have associated pleural effusions. All of these findings are more consistent with a bacterial pneumonia. With viral pneumonias, you tend to have a alveolar interstitial or interstitial syndrome pattern. We have diffuse B lines bilaterally. The severity of the B lines will correlate with the severity of the underlying disease. And if you do see subpleural consolidations, they tend to be focal, small, and less than a centimeter. So, and there's about, when they looked at this, there's about an 82% interim observer agreement on being able to differentiate a bacterial pattern from a viral pattern. And the overall sensitivity for lung sonography for detecting some of these focal consolidations or subpleural consolidations is very, very high, and exceeds plain radiography. It does occasionally miss a pneumonia that doesn't communicate with the pleura. So the consolidation or pathology has to be contiguous or communicate with the pleura to enable the ultrasound signal transmission. When you see a lung consolidation, you have to keep a broad differential in mind and apply it to the clinical context. So it could represent a pneumonia, pulmonary embolism, lung cancer, metastatic lung disease, atelectasis, or lung contusion, just because all of those disease processes can lead to loss of aeration, air trapping, and potentially inflammation and fluid, which allows you to visualize the lung due to a combination of all of those things. So it's important for you to apply that and clinically integrate it in an appropriate context. Once again, the B lines tend to be diffuse, tend to match and marry the severity of the underlying disease process. And once again, your differential diagnosis is everything from viral pneumonias to pneumonitis, bronchiolitis, and diffuse parenchymal diseases, especially in neonates, everything from RDS to BPD, meconium aspiration syndrome, pulmonary fibrosis, neonatal ARDS, and then cardiogenic and non-cardiogenic causes of pulmonary edema, as well as multifocal bacterial pneumonias. All of these tend to have a diffuse B-line pattern and are termed alveolar interstitial syndrome. The pleural line of interest tends to be preserved in cardiogenic and non-cardiogenic pulmonary edema and tends to be lost in the infectious or other inflammatory processes. So that's a really helpful thing to recall. And we're going to close it out with 2 slides. Just when you're looking at newborns, this is really, really fascinating. So just when you have a newborn that within minutes or hours of birth transitions into neonatal life, there's some very, very dramatic changes, as we all appreciate. You've got a PDA, a PFO, and lungs that are full of fluid in utero. And as soon as you are delivered and you start to take your first several breaths, all of a sudden those terminal alveolar units that are full of fluid become aerated. And as they're becoming aerated, there's additional really significant physiological changes that are happening. You have the umbilical cord that gets clamped, and then all of a sudden your systemic vascular resistance goes up. And then over time, as you clear the fluid from your lungs, your pulmonary vascular resistance goes down. And then your PDA and PFO, which are ways of bypassing your lung in utero and shunting blood from the right heart to the systemic circulation, all of a sudden your PDA physiologically starts to close within hours to days of birth. And then in the accompanying weeks, your PFO in a majority, 66 to 80% of patients will close as well. And what that functionally does is that starts to force blood flow going through the lungs, and the lungs, as they become aerated, your pulmonary vascular resistance starts to drop, and by about 2 months of age, you get to adult physiology. But this has really profound implications into what your lungs and what normal lungs look like in the postnatal phase when you look at them with ultrasonography. There's a series of studies done. This slide is from Blank et al. In one of the studies that they did, and they looked at what do lungs look like immediately after birth. And when you see a newborn, as they're taking their first breath, their lungs are hepatized because they're not aerated and they're fluid filled. So you basically get kind of diffuse tissue-like appearance to the lungs. As the neonate starts to breathe, you start to clear some of that fluid and you start to get some air as well as atelectasis. So you get these air bronchograms. Then you get kind of that white lung, diffuse white lung appearance because you have multiple B lines, and you start to get diffuse B lines and coalescent B lines, and then the B lines clear, and you start to get the A lines with a paucity of B lines. That typically happens in the minutes to hours following birth. The exact timing is variable, but what's really clear is the overall density of B lines correlates with the physiological clearance of lung fluid in normal neonates. So it's a really, really impressive pattern. And then usually within several hours of birth in normal neonates, you start to get this A-line appearance and a more normal lung appearance, which is scattered B lines, as opposed to a tissue-like hepatized appearance immediately after birth. So a little bit about the module. So we'll talk a lot about the course. We'll scan through some cases, but just so everyone understands, when SonoSim creates content, for those of you that are not familiar with SonoSim, it's created in a modular format. And it's done so for this reason. There's a progressive consensus, as many of you already appreciate, of what it takes to develop ultrasound competency. And those have been, Delphi consensus agreed upon, but there's basically about 7 general criteria on an application by application basis of what it takes to become competent in ultrasound. So let's say we want to learn about pediatric lung sonography. What would it take to become competent on that particular ultrasound application? It's knowing the indications for an examination, having applied knowledge of the ultrasound equipment, how to manipulate it to get the images that you want and record them, how to optimize the images, how to perform a systematic examination, how to go through the lungs in a systematic way and get the information that's required, how to interpret the images, how to document the examination, and most importantly, how do you actually take an image that you've acquired, interpret it, and integrate it into medical decision making. And the way the ecosystem for SonoSim works is you have courses that are cloud-based that can be accessible through any internet-connected device, whether it's a mobile phone or a PC. So those are the courses. And with the courses, that's where you acquire the knowledge. And we do what are called in-module questions that help reinforce learning and engage learners. And then when you're through a course that can be anywhere From 3 to 4 hours of CME credit, you undergo a mastery test. And if you pass that, that documents that you have achieved some level of understanding of the content. So once you actually have the baseline knowledge of the topic, then you actually have to develop the image acquisition and image interpretation skills. That's the SonoSimulator. And we'll scan 3 cases today. 3 real pediatric cases and apply some of that knowledge. And here it's learning how to acquire and interpret the imagery. And concurrent with that, we have what are called imaging protocols that are provided either as DMS protocol assignments if you're a sonographer, or if you're a sonologist doing point of care ultrasound module assignments. So these go through the imaging protocols. The most critical images and steps and formats that you should follow to match your respective societal guidelines for imaging. If you were going to do procedures, so let's say you learn pediatric lung sonography and you identify a pleural effusion, you're worried about empyema or parapneumonic effusion, here you would potentially do ultrasound guided thoracentesis. So there's procedure modules. And then there's our SonoSim Live Scan with Case Builder that helps instructors and teachers train people and assess how well learners can actually take knowledge and apply it towards medical decision making. And then there's a background SonoSim performance tracker application that's part of our ecosystem that really helps you manage your learners, provide feedback, track performance. So that's a little bit about the ecosystem so we know what we're talking about. So we're going to transition now to actually scanning 3 SonoSimulator cases and applying some of the things that we've talked about.
Dr. Savitsky, we'll give you a moment to switch over to the SonoSimulator and prepare the 3 pediatric cases. At this time, I'd like to remind our attendees that they may ask questions in the chat, and we will answer all questions at the end of the session during the Q&A portion. Thank you.
All right, so now we've transitioned into the SonoSimulator. Presumptively, someone's done the SonoSim course, they've passed their mastery assessment, and now they have their module assignments. So it's really having them apply some of the principles that they've learned. I have a probe in my hand. I'm going to go to the lung sonography module and go to case 1. So this is a 86-day-old X28-week infant with a history of BPD. Now has developed a fever, coughing, and O2 desaturations. We're going to load the case. Once again, there's the history, and it's asking us to evaluate his lungs with grayscale and M-mode ultrasound imaging. Quick probe calibration. So now I just have the probe in my hand, and I'm going to scan along the chest. So here I'm going to scan along the right anterior chest. I can see some pulsation, cardiac pulsation. I see some B lines here. I go into a transverse plane. And then once again, here I'm seeing really, really dense coalescent B lines along the right anterior chest. I'm going to go and change my imaging window here, and I'm using a linear transducer. I'm going to move down to the right mid-axillary line. And here, once again, I'm going to see the liver, really, really tachypnic patient. And once again, I'm seeing dense consolidations. So here I'm seeing the lung moving up and down. I'm seeing the liver. So I'm scanning right at this junction here and seeing, once again, dense coalescent B lines. I'm going to migrate over to the posterior chest on the right side. Initially, I'm going to scan in a parasagittal plane and once again see a coalescent B line pattern to almost a white lung pattern here on the right side. I'm going to rotate in, and by rotating in here, now I'm actually scanning in a transverse oblique plane. You see the pleura, it's irregular. There's some subpleural focal consolidations where there's some image dropout. So there's loss of aeration here. So I actually see a little bit of kind of tissue-like appearance. And then once again, these diffuse B lines. So here, by scanning in this plane, I'm actually getting in between the ribs. And when you get in between the ribs, that's when you're able to get this wonderful image and really, really detect some consolidations that can be very, very difficult. So you can imagine if I only scanned in this plane here, and I had a consolidation that was closer to the spine, unless I slid over, I would miss it. But by virtue of going into this transverse oblique plane, I'm able to capture much more of the lung. So Here, I'm going to go into the left anterior chest. I'm looking at the contralateral side. And as I look over here, once again, I see very, very dense consolidation. Looks like white lung appearance. And then down here, I'm starting to see most likely what looks like spleen. I'm going to go over to the left mid-axillary line in a similar way. And I'm going to look here. Once again, tachypnic. I see a focal subpleural consolidation every once in a while coming out here with a very, very diffuse B-line pattern. I'm going to go along here to the posterior chest. And I see very similar findings on this side that I saw on the contralateral side. So just kind of reviewing the clinical history of this patient with BPD and a fever, this looks like findings that are consistent with what I would say BPD. You have diffuse pleural line thickening, irregularities, confluent B lines, focal subpleural consolidations. Cannot really exclude a superimposed disease process, whether it's a viral or bacterial infection, just based on the density. So the differential of this patient would be a severe alveolar interstitial syndrome. Remember, it's everything from viral pneumonias to pneumonitis, and but the findings are also consistent with underlying BPD, so it'd be comparing to kind of baseline findings. This patient actually had a tracheal bronchus that was documented on chest CT imaging as an additional congenital anomaly, and was thought to have a viral syndrome superimposed on their underlying BPD. Going to advance to a additional case, and we'll look at a little older patient. So here we have a 15-year-old patient that presents with a cough and a fever, and we're asked to evaluate her lungs with grayscale and M-mode imaging. So when we actually look at the anterior chest here, here we are using a linear transducer. You can see the ribs. You can see there's much more generous soft tissue here. And if the lung pleura is a little difficult to discern, you can apply M-mode Doppler. You apply M-mode and you look at movement over time. And then you actually see as you apply it, you see a seashore sign where you see signs of movement over time. That's very, very different than the static lack of movement that you see. So this helps you identify that there is lung movement and lung sliding on this side. So we're going to come down here and we're going to show as an example a curvilinear transducer. So once again, with a patient with a larger body habitus, you apply a curvilinear transducer. You can see the footprint's different. Here's the ribs, and here you can see much better that there is lung sliding. I'm going to move down to the right mid-axillary region here, and we're going to look at the right mid-axillary region. And here we're able to see the margin of the liver and some lung movement here, and there's not a significant pleural effusion because there's no anechoic fluid collection there, so that actually looks normal. We're going to go over to the right posterior chest, and once again, if we can examine along the margins of the intercostal space and see if we can identify the lung there, we can see some lung movement and no significant B lines. So far the right lung looks pretty normal. As I come over to the left anterior chest and examine in a similar way, once again using the linear transducer, I can look and I can see what appears to be a lung sliding. Once again, if there's any doubt, you can apply the M mode. And once again, you can see that there's a seashore sign, so signs of movement over time, which is this speckled pattern, as opposed to the barcode sign, which is there's no movement as evidenced by this linear pattern. So there, it looks like there's good lung sliding. There's no pathology that we see. We're going to switch over to the curvilinear transducer again in the left anterior chest. And maybe an occasional B line, but not more than one. As I turn into a transverse oblique plane and try to get in between the intercostal space, I see once again no significant pathology. I'm going to move down to the left mid-axillary space. And once again, as I look here, I see lung sliding and do not really see much in the way of pathology. So far, I'm not really finding much. And once again, This was a 15-year-old that developed a fever and a cough. So we're just trying to understand why that patient has that. Now when I actually look in the left posterior chest, boom, all of a sudden now I actually see significant pathology. So here I can see pleura. Pleural looks thickened or even absent here. And then once again here I start to see a hepatized tissue-like appearance. There's loss of aeration. This is a consolidation. Looks like an irregular margin. And occasionally I see a white hyperechoic signal here. I'm going to try to get in between the lungs using a transverse oblique plane. Once again, the plane I'm trying to get in is just in between the lungs. So if I'm able to do that, or in between the ribs rather, if I'm able to get in between the ribs, I can see that there's dense consolidation, a lot of trapped air. So I see some air bronchograms. And this is a relatively large consolidation, 5 to 7 centimeters at a minimum. So this is very consistent given the clinical context with a bacterial pneumonia. So in summary, you've got focal findings in the left lung base with consolidation, irregular B lines, or irregular pleural lines, coalescent B lines, diffuse air bronchograms, lung slidings present, no pneumothorax. So it's consistent with the left lung inferior lobe bacterial pneumonia. Last case that we'll do is we'll pick this one. So once again, pediatric patient, but on the older side, 18-year-old male presents with cough, pleuritic chest pain, and fevers. And we're going to examine the lungs. So here, I just look at the lung. I see lung sliding. I don't see any B lines. Once again, using a linear transducer. I'm going to go and use the linear transducer on the right side here. Once again, much more difficult because of the image depth. So I'm going to move over to the posterior side on the right, and I'm going to look with the curvilinear transducer. Once again, I can see pleura, I can see ribs, a little difficult to see lung sliding, but I see A lines, everything looks normal. Now I come over to the left side, once again, linear transducer, and then all of a sudden here I see a thickened pleura, I see some dropout, some consolidation, I see this dark anechoic area that may represent fluid or loss of aeration. So we'll have to kind of follow that down a little bit lower. We go down to the left mid-axillary line. I look with a linear transducer, and here I see some movement, which looks like a lung parenchyma. I see rib margins here, and I see dark anechoic signal. Increase my gain a little bit. And this dark anechoic signal appears to be fluid, so it looks like there's a pleural effusion here in the left side of the chest. When I come around here to the left posterior chest, here I see the diaphragm and what appears to most likely be a splenic margin. And then here, this looks like lung with a very, very large surrounding pleural effusion. So this is, a moderate to large pleural effusion. You see compressed lung here, trapped by the fluid around it, the diaphragmatic margin. So this looks very, very consistent with a large left-sided pleural effusion, so presumptively a parapneumonic effusion if we put it in clinical context. So here we see lung sliding bilaterally. The right lung appeared normal, but in the left lung, there is pathological B lines, then the left upper lung, a trace effusion, then a large pleural effusion was seen with compression of the left inferior lung parenchyma. Air bronchograms were seen that was consistent with a hepatized appearance of lung consolidation that could arise from bacterial pneumonia. So this looks like a bacterial pneumonia complicated by a pleural effusion that could be a parapneumonic effusion or even an empyema. So just some examples of applying imaging in multiple different planes, transverse oblique, as well as parasagittal, and then using a lot of the artifacts that we talked about, whether they're B lines or coalescent B lines or a white lung appearance, as well as lung sliding and different modalities to identify lung sliding such as M mode, and then looking at pleural effusions and putting all of those findings into clinical context and helping to narrow the differential diagnosis and hopefully arrive at the correct diagnosis and optimize patient management. So 3 cases, 3 examples using the SonoSimulator to really learn image acquisition and image interpretation.
So in conclusion, we've gone through a lot of the principles of lung sonography. We've seen them applied with 3 real life cases. And just to close our time out today, lung sonography is used to evaluate pediatric patients as well as adults of all ages. Understanding the age-dependent anatomic and physiological changes is important because that influences what you see with lung sonography. And then lung ultrasound, once again, it's a misnomer to call it that in some ways, and it primarily involves identifying imaging artifacts that arise from the pleural air interface of normally aerated lung regions, and occasionally visualizing non-aerated pathological regions of the lung, and then taking those findings and having to put them in a clinical context because it usually attaches, or those artifacts are attached to a broad differential that as a clinician you're going to have to marry the findings up to the patient presentation. And then, lung ultrasonography, whether you're a sonographer and you need to better understand the pleura in the lungs, or you're a point of care user, especially someone that sees a lot of pediatric patients, it just is such an efficient way of really making very, very precise clinical assessments of patients in real time. So it will just make your life better. You'll help improve patient care, and it'll improve your job satisfaction. So very, very bullish and very excited about the pediatric lung sonography module, and hopefully it helps you learn as well as educate your trainees and learners on a really, really amazing modality. Thanks so much, and appreciate spending the time with you, everybody, today.